Yes, we are live on YouTube. Hello, welcome to the IPA-UNICEF-WHO webinar on Do No Harm as Respond to COVID-19. I am Amruta Vadnerkar, working with IPA India office. On behalf of IPA, I would like to thank you all the speakers and viewers for gracing this webinar. Please follow our YouTube channel for more exciting future webinars. Follow us for more updates. I would request Dr. Jonathan Klein, IPA Coordinator of Development, for the opening remarks. Thank you.
Good morning and good evening or good afternoon, everybody, and welcome to today's webinar. This is the latest in a series of webinars that the International Pediatric Association is conducting in collaboration with UNICEF and with the World Health Organization. We thank the U.S. Agency for International Development for their support for part of this particular webinar on the issue of Do No Harm. And I want to mention the webinar series is one of several activities that IPA has with UNICEF. In addition to the webinar, there is a series of issue briefs that have been developed and are being released. The first one is now on the IPA website, and it addresses the epidemiology and impact of COVID-19 on children, adolescents, and pregnant women. It takes a specific and direct look at the issue of the multi-system inflammatory condition that some children have been dealing with the condition. And I'd refer you to the website for that issue brief. The second issue brief in the series will come from today's content with a follow-up literature review. And the entire program is coordinated by Dr. Zulfi Buddha and myself on behalf of IPA, and by Gagan Gupta and Stephen Peterson from UNICEF, and by Wilson Ware and Dr. Banerjee from the World Health Organization. So we thank you for your attention there. The third aspect of the collaboration is to bring back priorities from pediatric and child health leaders globally to UNICEF and WHO. And so if you have issues that you're confronting as you deal with the healthcare system for children and the COVID pandemic, please let us know. There's a way to communicate with us through the IPA website or through the various social media channels. Dr. Naveen Thakur and the IPA staff, Amruta Vadekar and Shraddha Udikar in India, are able to respond to those, and we'll bring them into the discussion, or we can bring you directly into the discussion as that goes forward. So without any more delay, let me go ahead and introduce Dr. Gagan Gupta from UNICEF, who is one of the co-moderators for today's webinar. And again, thank you for being here. Please subscribe to the IPA's YouTube channel if you want to make sure that you get notices for the next webinars in the series. We're conducting these in both English, French, and Spanish. And the next webinar up in the English series will be on reopening schools. What do we need to do that safely? Thanks so much. Over to you, Gagan.
Thanks, John. Good morning, good afternoon, and good evening, colleagues. Wherever in the world you are at this moment in time, contributing towards the global response to COVID-19. I'm Gagan from UNICEF headquarters in New York, your moderator for today's session. I'm joined by Professor Kinnan, who is the co-moderator along with me, and together we will be navigating this session for next 90 minutes. As we mount our collective response to the rapidly increasing number of COVID cases, it will be equally critical that we do no harm in the process, be it while providing the routine care, or while making decisions on oxygen therapy, or in addressing infection prevention and nosocomial transmission. Just to put the things in perspective, a recent meta-analysis of 2,000 plus COVID patients showed 72% antibiotic usage, adding further to the silent epidemic of antimicrobial resistance. Similarly, a Lancet publication earlier in the week showed 44% of the 200 frontline healthcare workers enrolled in a study at London Hospital had evidence of COVID infection, highlighting not only are the health workers at a greater risk, but may also contribute to the transmission of COVID. Similarly, we are seeing examples from some of the countries in Asia where breastfeeding is being discouraged and mother and baby are separated if mother is COVID positive. This gap between evidence and practice is what we aim to address in today's webinar on Do No Harm as you respond to COVID-19. And to take us through this, we have with us Susan Irmer, Professor of Pediatrics at University of Colorado and Fellow American Academy of Pediatrics. She's also a Senior Advisor at USAID, but today she would be speaking more in her capacity as Professor of Pediatrics at University of Colorado. She will be focusing on the clinical profile and management across the MNCH spectrum. And thanks, Susan, for all the coordination for this webinar. We will also then hear from Vicky Willett, who is in the IPC team of the WHO. She's a registered nurse with 15 years of solid experience on the ground in infection prevention and control. Thanks, Vicky, for being there. We also have with us Hamish Graham, who is a pediatrician and researcher with University of Melbourne and a global expert on oxygen systems and pulse oximetry. He will be speaking on safe and effective oxygen systems. And last but not the least, we have Aman Polugan, who is the president of Indonesian Pediatric Society and will bring the perspective from the pediatric front lines in Indonesia, the pulse that we all need to be connected to. With this, I request Professor Kinnan to just say a quick hello to all of you and then over to Professor Susan.
Thank you very much. I just wanted to add my welcome to everybody from the 1 million pediatricians around the world associated with the IPA through its 147 national and regional organizations. I think it's an exciting panel today. I think the series has been very, very useful and look forward to the written briefs that can be used over and over. So thank you, and let's proceed. Susan, I think you're the first speaker, and you've been introduced. The topic's been introduced. She's a great friend. Thank you.
Thank you so much to all of you for this opportunity to present Do No Harm as we respond to COVID-19. So the origin of the theme for this webinar really sprang from a series of Do No Harm briefs on inpatient newborn care that dealt with really essential themes like oxygen use, thermal protection, human milk feeding, infection prevention, and family participation in care. These really recognized the hazards of not providing these essential elements of care, but they also recognized the hazards of interventions that might have unintended negative consequences. A good example of that would be, for example, unregulated oxygen use and the complication of retinopathy of prematurity. So for this webinar, we'd like to expand that theme of Do No Harm as we respond to COVID-19, really to encompass pregnancy, in-facility care of newly delivered mothers and their newborns, and then the return of the child and the family back to care in the community. Certainly, we recognize that the greatest risk of harm probably comes from interrupting the essential elements of routine care. So that was really brought out by this referenced modeling study by Robertson that used the LIST model to estimate the thousands of additional lives lost that might result from differing levels of disruption in those essential elements of care. So what we really want to focus on is first maintaining essential high quality care in the face of the possible disruption that the pandemic is causing, and then incorporating special preparedness and protection in the face of this COVID-19 pandemic. Certainly a big part of the challenge of combining those two is keeping up with the new understanding of biology and of clinical presentations and management as we learn more about this virus. This is some of the most topical news about the potential for not only droplet transmission, but also airborne transmission of the virus. And referenced there is the very recent WHO publication dealing with that and the infection prevention and control implications that our next speaker is really going to be discussing in detail. So this really has implications, as we know, not only for aerosol generating procedures in healthcare facilities, but it may also have relationship to our everyday life as we return to the workplace, as we return to the classroom, especially in crowded spaces with inadequate ventilation. The droplet spread from speech, from singing, from vigorous exhalation, as in the second stage of labor, might really be spreading particles that contribute to contagion. And so this is part of what has led to the recommendation for universal face coverings at all times in public to decrease the risk of transmission. And certainly we know that decreasing transmission and preventing infection is central in our approach to do no harm in pregnancy. So what about pregnancy? We know that pregnant women have a risk of acquiring COVID-19 that's very similar to that of the general population, largely on the basis of social determinants, a woman's occupational exposure, how crowded her household is, how many people she is exposed to. But what has been really striking about infection in pregnancy is the very high prevalence of asymptomatic and pre-symptomatic positives among pregnant women. So here are a couple case series from New York that show very early on in the pandemic a distribution of illness that was quite similar to that of the general population. And we can see in that early series, a third of these women were asymptomatic. Well, that was surprising. Later on in the pandemic, as it reached its peak in New York, universal testing of pregnant women was instituted, and they found 11% of total OB admissions were positive at that time, and almost 80% of those women were asymptomatic or pre-symptomatic. Now, many of those went on to develop symptoms during their hospitalization or even after their delivery, but on their presentation to the health facility, almost 80% were asymptomatic. This led to the recommendation for screening for symptoms and exposure of all pregnant women on admission to facility, and also providing the very best possible protection for labor and delivery staff who really do have an intense exposure over hours of labor very close to their patients. So although women do not appear to be more susceptible to infection, pregnant women with comorbidities might be at increased risk for severe illness compared to their non-pregnant age equivalent counterparts. Severe disease appears to be concentrated in the third trimester and probably relates to the respiratory physiology of pregnancy, when pregnant women late in gestation have really very little respiratory reserve. The risk factors that we're familiar with for severe disease apply here: vulnerable populations, obesity, diabetes, hypertension, likely also relatively older age. And pregnant women are more likely to be hospitalized and receive respiratory support, but have no apparent greater risk for death. Multiple case series and systematic reviews have suggested that there's an increased incidence of emergent delivery for maternal and fetal indications, and postpartum deterioration of women has also been reported. Let's look at these data from UCOS. This is the UK obstetric surveillance system, and it really represents sort of the next phase in data collection. This is a nationwide surveillance system in the UK linked to their national health system. So they were able to look at admissions over March and April. About 10% of these pregnant women received intensive care, and 5 of the women died. This was early in the pandemic in Britain. More than 20% of pregnancies were delivered prematurely, and this was mostly for maternal indications of severe illness or for fetal compromise. And again, here we see those familiar risk factors that were reflected in this population in the UK of women with more severe disease. This is another example of a registry that's a voluntary global registry for real-time data collection and then access to that data. This is actually structured as a basis for research. Interestingly, there are some signals now emerging from some of these cohorts in New York of placental pathology with decreased fetal perfusion and thrombi on the fetal side of the placenta. So networks like this are going to be very important for focusing research questions and having aggregate data that will allow us to answer some of these questions in a much more timely fashion. Another registry is a different model. This is the Priority Registry in the US. And this really recruits patients directly to contribute to this registry. And also physicians can refer women directly to this. It's really trying to document patient experience longitudinally, including 2-year follow-up of the women and their newborns. And you can see from this slide that women are enrolling in this quite early, so less than 10 weeks of pregnancy, early in the first trimester. And really, this is the way that we're going to be learning more about the evolution of the effect of COVID-19. At this time, it appears to have no strong teratogenic properties, for example, as Zika did, but there is much more to learn, and it's these kind of registries with large aggregate data that will help us answer that more quickly. So let's summarize, do no harm. What can we do now with respect to pregnancy? We need to support women to receive timely and accurate information to protect themselves from COVID-19. We need to really maintain the continuity of prenatal care. It's important to recognize those risk factors. And we may have to be innovative about the way that we're accomplishing this with home visits, with teleconsultation. But it is so important to continue to obtain screening, testing, and then direct women for delivery at an appropriate facility. We also need to help them to strengthen birth planning around transportation, around finances, presence of a birth companion as these family circumstances are changing rapidly. And as professionals, we really need to contribute to data collection on COVID-19 in pregnancy. So now let's turn our attention to the newborn. Most babies born to women with COVID-19 are healthy. Some do need special care for prematurity, for asphyxia, for respiratory disorders, but largely these complications are unrelated to COVID-19 itself. Especially adverse pregnancy outcomes, miscarriage, stillbirth, these still go on, but by and large, they have had no clear relationship to the SARS-CoV-2 virus. The rate of newborn infection at birth appears low in the range of 0 to 4%, and there has been very low risk for intrauterine or intrapartum vertical transmission documented. In fact, most infection appears to result from immediate postnatal transmission. And it's important to recognize in the systematic reviews and case series, as the one referenced here, that there have been variable approaches to infant separation in different countries and variable access to strict hygiene and infection prevention for families. I think it's useful to really examine this whole concept of vertical transmission more closely, because it's been very concerning to pediatricians and obstetricians. When we think about vertical transmission, it really can be broken down into 3 different types. Intrauterine transmission deals with hematogenous spread through the placenta or infected amniotic fluid. Intrapartum transmission relates to exposure to infected maternal blood, infected secretions, or feces. And immediate postnatal transmission derives from infected respiratory secretions, either of a family member, a caregiver, or the mother herself, and also may relate to breast milk. This has been questioned as a possible vehicle for infection. But let's look at the evidence. Although viral particles have been documented in many of these body fluids and tissues, the evidence of actual infectivity or persistence of the virus in the fetus or newborn has been relatively limited. Just last week, there was a case report that documented transmission via placental tissue, and that was a well-documented case study referenced here. However, this occurrence is really quite rare, and intrapartum transmission appears to result mostly in contamination rather than true infection. Certainly, by and large, the most common route of transmission is that of immediate postnatal transmission through respiratory secretions. Although a few positive cases of virus isolation in breast milk have been identified, there as yet is no evidence of infectivity, and that evidence is very well documented in the WHO breastfeeding brief referenced here. So again, let's look at neonatal data from the UCOS surveillance system. As we've said, almost 20% of those babies were born prematurely, an increase over the baseline of about 7–8% in the UK. But that may represent the access to intensive care and really an abundance of caution in delivering women. Much as with adult disease, we're learning of better ways to provide respiratory support to adults with COVID-19, and these data may change. There certainly were reported stillbirths and neonatal deaths. However, again, these were unrelated to SARS-CoV-2 apparently. And a low percentage of babies had a positive test for the virus, and the criteria for establishing congenital infection in this cohort were not met. Here's another example of a neonatal registry that's really focusing on newborn outcomes with real-time data collection that is hosted by the American Academy of Pediatrics section on neonatal perinatal medicine. You can see some of the data that are being collected here, very detailed information on management and outcomes of the newborns. And again, I think it's striking to see the very high rate of asymptomatic maternal status at admission. This is the dashboard from 7-Eleven, and this registry is updated weekly. So this is really providing real-time feedback as to what is going on with the newborn population at a national level in the United States, and is beginning to help guide management. This is another outstanding example of a real-time registry database, the Pan American Health Organization Perinatal Information System. This creates not only a national and regional database, but individual facilities can access their data. So they have a ready-made data entry template. They can aggregate their data, they can look at it, and these forms even provide standardized maternal perinatal guidance for management of COVID-19 cases in pregnancy. What about the management of the newborn in the perinatal setting? There has been very little consensus in national practice guidelines. This Cochrane review surveyed national guidelines at the beginning of the pandemic and found actually very little consensus. The major consensus was around the need for high-level PPE protection of health workers, universal masking for pregnant women in facilities, vaginal route of delivery, except where C-section was indicated by obstetrical concerns. But for the rest of management, there was really wide variability. And for those of you who practice in tertiary facilities, the guidance also around management of the very ill newborn for resuscitation, for intensive care, has also been variable and incomplete. So I think part of what we need to do during this pandemic is really continue to examine the evidence and to examine our practices and ask, are we really doing the best to support the mother-newborn dyad together with the goal of minimizing separation, except in those very unusual cases of severe maternal or newborn illness. So our focus really needs to be on the basics, keeping baby with the mother, but doing that in a safe way. Delaying clamping, umbilical cord clamping whenever possible. Using very good hygiene, providing masks for protection against that respiratory droplet transmission, and encouraging breastfeeding as a life-saving intervention. We also need to do better about some of the basics. Putting emphasis on pre-discharge preparation is always, I think, an issue. And we know that we need to discharge after certain criteria have been met. During the pandemic, I think there's a tendency to want to discharge as soon as possible to get that mother out of the facility with her new baby. But we need to assure stability. We need to assure that mother and baby can be cared for adequately in the home, and that includes infection prevention and hygiene. And we also need to make sure that families are educated on danger signs, not only the routine danger signs, but also the very subtle danger signs of COVID-19 disease in the newborn and the potential for deterioration of the mother post-delivery and post-discharge. This really means very specific and concrete follow-up needs to be made. A telephone number that works, emergency transport that's readily accessible, perhaps innovations in home visitation or arranging scheduled appointments at set times with separation of well and sick patients so that people are not sitting in the courtyard for hours exposed to potentially sick neighbors. So what can we do now with respect to newborn health and perinatal in-facility care? We really need to focus on protecting healthcare workers, patients, and families. We need to review our operational guidance to promote essential newborn care safely, avoiding unnecessary interventions, and really focusing on minimizing separation of mother and newborn in the health facility, co-locating them when possible, promoting skin-to-skin contact, promoting breastfeeding or feeding of breast milk. And then finally, strengthen family guidance on recognizing illness and seeking care. So lastly, I want to consider, as we move from facility back to the community, the ways that we can protect the child and the family in the community, recognizing the very different situations to which they will be returning. Again, the essentials of postnatal care are now one of the weakest links in the chain. And perhaps this is a chance to really do that better in some innovative ways. We need to continue monitoring, we need to continue preventive care, and we need to really focus on recognition of illness. Some very specific factors related to the very non-specific manifestations of COVID-19 in neonates and infants who can present with fever or not, hypoxemia, which is silent, poor feeding, maybe only neurologic signs. And we also need to sensitize healthcare workers to the possibility of postpartum deterioration with COVID in mothers. Also, we're beginning to receive data signals that domestic violence really is increasing in populations that have been put under lockdown orders or that are suffering economic hardship in the pandemic. And there has been reported from a children's hospital in London, a 15-fold increase in non-accidental trauma this spring compared to the prior year. So we need to be sensitive to domestic violence, non-accidental trauma as additional hazards. And finally, with our movement and our social connections disrupted, it's really, and economic activity disrupted, it's really important to ask questions about food security and to provide suggestions about developmental stimulation and early learning in the context of the family. I want to leave you with this brief case description for your reflection. An infant was born at term after an uneventful pregnancy. On day 4, the baby had poor feedings, but no sign of respiratory distress, some perioral cyanosis, but no fever. The baby's oxygen saturations were in the 80s. Now, this mother had developed a fever without respiratory symptoms on day 2 after delivery. That prompted testing of mother and baby for SARS-CoV-2, and both were positive. This baby was admitted to the NICU, received 30% oxygen and nasogastric feedings for 2 days, and then did quite well. But I would ask you to reflect, if this child were in your community, Are there systems that are strong enough to bring that child to attention in a timely way and to protect that family's health? So doing no harm as we move into the community, we need to maintain monitoring, surveillance, delivery of preventive care, emphasize education of parents, provide resources for communication, and sensitize health workers to special issues during the pandemic. We also need to contribute to ongoing data collection on COVID-19 outcomes in neonates, young infants, children, and parturients, because this is the way we're going to begin to learn about the long-term consequences of this disease and continue to keep our management practices current. I'd like to leave you with these 3 principles for do no harm as we respond to COVID-19. First, protect healthcare providers, because without them, there really is no care. Deliver high quality care, maintaining essential services, and maybe doing that in innovative and adaptive ways. And also examining evidence to keep our management of COVID-19 current and best practice. And finally, take measures to limit the pandemic. Thank you so much. And I'd like to now pass the baton over to Vicki Willett to talk more about these measures to limit the pandemic and infection prevention and control.
Thank you, Dr. Niemeyer, for that really interesting presentation. And thank you to everyone here who has invited me to participate in this presentation today. I think you'll find that a lot of the messages that will come from my presentation on infection prevention control really mirror those of Dr. Niemeyer. So am I able to change the slides here, or okay? So I guess someone's going to do it for me. So just a quick overview of some of the objectives I hope to cover in today's presentation, and that is I just want to review and describe the infection prevention and control measures, really focusing on rapidly identifying patients at risk for COVID-19, especially your maternal patients and of course pediatric. Talk a little bit about the IPAC measures for preventing transmission to our patients and keeping our health workers safe. And I was also asked to talk a little bit about strategies for managing PPE during shortages, which is occurring globally. The next 2 slides, I'm really just listed for you a number of the key WHO documents that are available online and the links for them that you may want to refer to related to infection prevention and control for COVID-19. So there's a number of IPC documents listed here, or infection control documents. Next slide, please. There we go. And then the additional documents I've included from WHO. We've recently in May released a clinical management of COVID-19, and there is a section on maternal health in this document. There's a new scientific brief that was published June 23rd on breastfeeding, and some clinical case record forms that are also available online if you're interested in any of that information. Next slide, please. So I can't stress enough the importance of physical distancing for controlling transmission of COVID-19, and especially in our healthcare facilities. Restricting the number of visitors, ensuring that we maintain at least 1 meter, and I'm really stressing a minimum of 1 meter. WHO has decided on that wording for very specific reasons related to the research. Many countries and regions have chosen to go 1.5 to 2 meters, which is great, but that minimum of 1 meter is really important that you maintain that kind of distance. And it's important that we maintain that distance where we can with our patients, but even more importantly, between our health workers. And this is where it becomes a bit challenging because health workers want to go to the cafeteria together, they want to take their breaks together, and we have to put things in place to really ensure that they're maintaining that 1 meter distance on their breaks. Dr. Niemeyer mentioned about the numbers of healthcare worker infections, and there is, definite consideration that there is health worker to health worker transmission occurring. So we really need to ensure that staff are maintaining that distance, and of course, good hand washing, refrain from touching and sharing of equipment, cleaning and disinfecting our environment, all of these sorts of measures. If you could go to the next slide, please. So the most important thing we can do to ensure that we keep a safe environment and safe care for our patients is to have a process for screening and triage. And there's sort of two elements with that. We have to make sure we have the right area, that it's in the right location as our patients are approaching either our health facility, or if it's in an office practice, that you have a process to identify the patients as soon as possible, should they be coming to your office for follow-up or appointments. If they could be done in another way, that's a better approach. If you can do it online or by phone or something else, that's one approach. But if they do need to come to your office, that you have some sort of process in place and that you have the space for that, so that patients are not standing around or sitting close to one another, that you've got that 1 meter of space or more, that you have the products available, access to hand hygiene, whether that's hand washing with soap and water or alcohol-based hand rub, that you have masks and PPE available, both for your patients, so masks for your patients and their visitors or caregivers to don, and also available for your staff. So there's a lot of elements that need to be in place to set up proper screening. And this should really be set up at any point where prenatal patients are entering the facility. And you need to also make sure that there's considerations given as to what the plan will be for their birth partners or caregivers that are coming with them in the event that they perhaps fail that screen. So that's a conversation that needs to be had with those mothers before they arrive. Where can, who will they have as a backup if they arrive and their partner perhaps doesn't pass the screening test? So next slide, please. With screening, as I've mentioned and can't stress enough, it's really important that we ensure all patients and their visitors are screened if you're allowing visitors. And of course, in a situation where there's a birth about to happen, it's important that they have some sort of access, whatever that may be, to their partner. And that partner's not allowed to enter, of course, if there's any signs or symptoms present. We need to make sure that the staff that are doing this screening are well trained, that they have clear descriptions of the signs and symptoms, that they understand the case definitions that need to be used, and ideally have an algorithm that they can follow that tells them what to do if this person, is identified as a suspect case, that they're able to do the steps that they need to rapidly implement the right measures. We really need to take a good history, a contact history for the mothers when they arrive, these patients, to ensure that they, we know if they have any potential high-risk exposures. It is really recommended that any visitors, as I said, are screened and are not allowed into the building if they have any symptoms, that the mothers have a backup partner. This should all be arranged prior to their delivery. And that pregnant individuals who are asymptomatic at the time of admission and have no history of high-risk contact, that they should not be considered to be a suspect case. Caregivers that are able to attend, or birth companions in areas that have high community transmission, and including those caring for patients, if you're taking care of patients with suspect or confirmed COVID-19, really should be encouraged to wear a medical mask in the clinical areas for source control, to prevent any transmission to others. So that's really important that you consider what's going on in your region and the use of masks. So if I can go to the next slide, please. I'm just going to mention briefly about testing that we're really encouraging that you follow your national and local testing guidance. Of course, testing is recommended for any patients with signs and symptoms of COVID-19. And of course, if you had a visitor fail the screen, that they be sent for testing as well. Testing of asymptomatic patients or pre-symptomatic really should be at the discretion of the practitioner or the facility, and you should follow the policies related to that. There's a lot of discussion around whether you should be routinely testing asymptomatic patients prior to delivery or prior to them coming in for a procedure. And we really have to recognize that there are some limitations with that sort of approach. There could be negative results, and as a result of it's still early in the incubation period, which may give us false sense of reassurance. So we have to keep that in mind. We certainly wouldn't want somebody's care to be delayed because they were waiting for a test. So there are risks with that. As I said, at WHO, we recommend testing for anybody who is symptomatic. If they're asymptomatic, you really need to look to what's going on locally in the epidemiology and community transmission in your area. Work with your facility that you're working in, your public health, and determine what the best approach is for your region. Next slide, please. So a couple of things around the basic infection prevention and control measures that should be in place so that we can safely care for any COVID patients that may show up in labor and delivery. Any patient suspected or confirmed to have COVID-19 should of course be placed on droplet and contact precautions immediately. Health care workers that provide care for these individuals should wear a medical mask, eye protection, a long sleeve gown, and the appropriate gloves. If this is in an area or in a circumstance where aerosol generating procedures are being performed, then we recommend the addition of airborne precautions, which means adding a respirator, that any procedure should be done in a properly ventilated room, preferably a single room, but it needs to have the adequate ventilation, and that ideally you limit the number of staff that are present for that procedure and that they're experienced in the work that's being done. So there are on the WHO's website a number of, we describe what is considered to be an aerosol generating procedure, and I've listed them on the slide here. And we also look at high flow nasal oxygen, non-invasive ventilation such as CPAP, and for now, we're recommending that those should also be considered for airborne precautions. So if you're having a situation where a mom is in distress, you may want to be looking at that. Ideally, patients with COVID-19 should be in a private room, but we also know that with hospitals at capacity, this has become a definite challenge. There's a shortage of single rooms or high occupancy. Regardless, it's important to keep a minimum of 1 meter space between beds. And when single rooms are not available, then we go to cohorting. And with cohorting, we're talking about putting together patients who are either suspected, would go with suspects, probable with probables, confirmed with confirmed. And so it's creating that space in the environment where those patients can be kept together. And at all times, they have to have at least 1 meter space between cases. So next slide, please. If possible, healthcare workers should be dedicated to care exclusively for COVID patients so that they have the necessary experience to do this. And as I mentioned, health workers should be wearing the appropriate PPE, which is medical masks, goggles, face shields, gowns, and gloves, and follow the hand hygiene recommended by WHO with our 5 moments before putting on their PPE, after removing PPE, and at all the other 5 moments. One of the big issues is during labor and delivery. And if you have a COVID positive mother, you would follow contact droplet precautions. One area of debate that is happening is, as Dr. Niemeyer mentioned, around whether or not the heavy breathing that may occur during labor is aerosol generating or not. To date, WHO, our stand is that it is not an aerosolizing procedure, and therefore you would continue to follow contact droplet precautions. But I think you really have to, again, look at your own practice, your own risk assessment, and determine whether or not what precautions are going to work best for that particular situation, whether you're going to upgrade to airborne or not. But just donning an N95 mask is not necessarily sufficient if you're thinking you need airborne precautions. You have to look at the whole package of ventilation, single room, that sort of thing. In general, for any other laboring mother, if they're not suspected to be COVID, we would suggest that you follow your usual protocols, conduct a risk assessment, wear the appropriate PPE, thinking about the amount of blood and body fluids that you may be exposed to. Next slide, please. And just in general, there's a number of other things that we need to keep in mind. Again, making sure that any equipment we use is single use when possible, or cleaned and disinfected between patients according to proper protocols and standards that should already be in place. That patients who are suspected or confirmed to have COVID-19 are not transported throughout the hospital. If they are, the health workers that are transporting them are wearing the proper PPE, that we limit visitors as much as possible. If the family member is going to be present, then they must wear, if the patient is COVID-19, appropriate PPE. And really, if all of these precautions should continue until the patient is no longer symptomatic. Next slide. So just wanted to bring to your attention that we do have a document in WHO that talks about the rational use of PPE and discusses the strategies to optimize the availability of PPE. So if we could just go to the next slide, please. Some of those strategies include minimizing the need for PPE. So it's really looking at your workflow and looking at different ways of approaching patient care, such as telemedicine in areas where that's available to them, looking at implementing physical barriers, such as plastic or glass windows, especially in your triage areas, emergencies, registration areas, really limiting the numbers of healthcare workers that have to go into a patient room by planning your activities carefully, bundling activities so that you're not using PPE more than necessary. And if PPE is shortage, you really have to think about what you're going to do about visitors and who's going to be assisting those patients from the family perspective. Next slide, please. Some additional key points, and although we know this is happening, our recommendation, according to the best practice and evidence, is that we don't extend or reuse PPE. But if you do have to do that, you really have to think about how you're going to do it carefully. We recommend extended use over reprocessing unless it's something that can be reprocessed. So if you're wearing your masks, you're going to wear them potentially for a longer period of time. Maybe your gowns are being worn for longer periods of time than what you would normally do. We're really, again, mask decontamination is not something that we have got good evidence to support, and it's definitely not recommended for surgical masks. There is some work being done on respirators by use of various hydrogen peroxide and UV radiation machines that are becoming available, so that's an opportunity. But we have to remember that if you're reusing or extending the use of PPE, there are limitations and risks with this, and it should really only be done as a last resort. And really looking at making sure that your organization has a good procurement strategy for PPE. Next slide, please. So just highlighting for you that we do have a document on cleaning and disinfection of environmental surfaces. And the key message, if you could go to the next slide, is that coronavirus is an enveloped virus and it has a fragile outer lipid envelope. So it's very susceptible to disinfectants, and it's more susceptible compared to viruses such as norovirus or rotavirus or even polio. And studies have evaluated that there are studies that have evaluated the persistence of COVID-19 on different surfaces. One study found that it remained viable for up to 1 day on surfaces such as cloth and wood, up to 2 days on glass, 4 days on stainless steel, 7 days on some, the outer layers, for example, of a medical mask. So the important thing is that this virus is susceptible to the disinfectants that we typically use in the healthcare environment, including our chlorine-based products, and that there are recommendations from WHO on proper concentrations. For example, if you're using chlorine, 0.1% for routine cleaning, 0.5 if you have blood and body fluids. We do not recommend spraying or fogging of disinfectants. There is no evidence to support this, and it's actually potentially more harmful to individuals. In general, patient care areas should increase the frequency of their cleaning routines and follow protocols for environmental cleaning and disinfection. We should keep the cleaning supplies in the isolation areas if that's what you have. Manage your waste according to your hazardous waste protocols and your national and local guidelines and regulations. And on the next slide here, I have a brief example of cleaning schedules that are recommended, that are available in our document. Next slide, please. So I just want to wrap up here with breastfeeding, because I know we're running out of time. And this is a really important issue. And at the time that we put out our guidance from WHO related to breastfeeding, there were no real confirmed cases of mother-to-child transmission, although as Dr. Neumeier has pointed out, there are some different transmissions that are starting to emerge, and this is continually evolving, so I think we have to be aware of that. But in general, cases that have occurred in infants have been generally mild. Overall, from the available evidence, WHO recommends that mothers continue to breastfeed and that mothers should not be separated from their infants, even if they have COVID-19. WHO recommends that, we recognize, that while this seems to contradict what we would normally say for infection prevention and control, that the balance of the risks really is different for infants and adults, and that the importance of that bonding time with their mother, the importance of continuing breastfeeding outweighs the risks and is more important to continue. In infants, the risk of COVID-19 is low. The infection is typically mild, and the consequences of not breastfeeding or separation from the mother and the child can be significant. Mothers shouldn't be separated, as I said, from the infants unless the mother is really too sick to care for her baby. And in that case, if the mother is unable to care, then we should have another competent family caregiver identified who can step in and help out. Really, mother and infant should be enabled to remain together and room in throughout the day and night, practice that skin-to-skin contact, kangaroo mother care, especially immediately after birth and during the establishment of breastfeeding, whether they or the infants are suspected or confirmed to have coronavirus infection. Really, we need to make sure mothers are counseled on performing hand hygiene before breastfeeding, if they're coughing or sneezing, to follow respiratory etiquette. If they have somehow coughed on their chest, they may want to wash their breasts before they breastfeed, but we're not saying that needs to be done every time. It's just if they think they've coughed on themselves. We are recommending, if a mother, especially if they're symptomatic, she should wear a medical mask, or if they're in an area of high transmission in the community and they're not sick or anything, that they may want to consider wearing a fabric mask when breastfeeding if they're asymptomatic, but in an area of high community transmission. So my few key messages, I don't think we can stress enough to be vigilant and really be aware of what's happening where you're working in your local context, and to follow the guidance from your local and national guidelines. Screening is a key step. We have to have good screening processes in place, immediately implement IPC measures, and of course, always follow standard precautions. PPE is important. We have to use it judiciously, and we really have to provide that counseling and education to mothers. And thank you very much. I think on my next slide, I just have a link for you on some additional IPC training courses if you're interested. Thank you, and I will now turn it over to our next speaker.
So over to Graham. Amish, over to you.
Thank you very much. It's great to be with you today. Today I'm speaking with you about something which is very close to my heart, that's safe and effective oxygen for children. Like the other presenters, one of my core messages is that we really need to do the basics and do the basics very well. I'll be sharing with you some practical things that we can do to improve our oxygen systems, and I hope that everyone will be able to take something practical back to their institutions and back to their colleagues. A quick acknowledgement that the tips I'll be sharing have come from a range of people and a range of groups over recent years, and particular call out to Professor Faladi from University College Hospital Ibadan, who will also be joining us for the Q&A a little bit later. So let's start by focusing our attention on a child. This is Amana, who is an infant who presented with pneumonia. You'll see in the left panel that she's very sick, she's breathing very hard. Her conscious state is a bit lower, and if you can see that flashing purple number on the oximeter, her oxygen levels, her SpO2 is 52, 53%, very, very low. The middle panel shows her just a few minutes later, still very sick with pneumonia, still breathing very fast, but now her SpO2 is 98% normal. And the right panel shows that she's been connected via nasal prongs to an oxygen concentrator and is receiving 0.5 litre per minute of oxygen. Now, I think you'll agree that this is a striking example of why oxygen is an essential medicine. And I'm sure you'll agree that every child in a Amana's situation should have access to safe and effective oxygen therapy whenever they need it. But unfortunately, data from many low resource settings suggests that most children who need oxygen will not receive it and will not receive it safely. A few years ago, we assessed the situation in 12 district level hospitals in Nigeria. We started by asking the question that's in many of the high level surveys: does your health facility have oxygen concentrators or cylinders? And most of the hospitals said yes, most of them had some oxygen source. Then we looked at the pediatric and neonatal wards and we tested all the equipment. Less than half the hospitals had a functional oxygen source on the ward. And then we looked to see how oxygen was being used, specifically whether staff were using pulse oximeters, whether they had any sort of guidelines. Only one hospital was using pulse oximetry and none had guidelines for staff to follow. Then we looked at what proportion of hypoxemic children and newborns received oxygen. And the result was shocking. Less than 20% of severely ill hypoxemic children and neonates received oxygen. Now, this tells me two things. First, oxygen access is bad and probably worse than we think. Second, often we get stuck on these binary high-level questions of whether there's equipment available without assessing whether the supply is functional, adequate, or reaching patients. And I've seen this in many of the recent COVID-related preparedness surveys. Now, this situation is replicated again across many different contexts, and you can reflect on how that reflects in your particular context. So how do we ensure safe and effective oxygen for sick children? Well, I think there's 5 key ingredients. First is we need to promptly and accurately identify the patients who need oxygen. And the key to that is identifying hypoxemia with pulse oximetry. Secondly, we need a reliable, continuous supply of medical grade oxygen. Thirdly, healthcare workers need to have the skills, the equipment and the motivation to use oxygen well. Fourth, technicians need to have the skills, equipment and motivation to maintain the oxygen equipment and set it up well. And finally, we need a holistic approach to oxygen systems. Now, I don't have time today to go through in all these in detail, but I do want to concentrate particularly on the ones that are quite clinically oriented. So let's start with hypoxemia. We know it's very common. In our work in Southwest Nigeria, we found that almost a quarter of unwell neonates and about 1 in 5, 1 in 6 sick infants had SpO2 of less than 90% on admission. Hypoxemia is also deadly. It increases the risk of death maybe 7-fold and has increasing risk of death the lower the SpO2 is on admission. So clearly the key to prompt and accurate recognition of patients needing oxygen is pulse oximetry. And in our work in Nigeria, we found that the biggest improvements in oxygen, use of oxygen, came not from introducing new oxygen delivery equipment, but by making pulse oximeters a routine practice. And there's some resources here to find out a bit about how we did that and what tips we learned from that. So this is a whole talk, pulse oximetry is a whole talk in itself, but I just want to put this out as a big lesson. Pulse oximetry is essential. If you're not already doing pulse oximetry routinely on all sick newborns and children, then we really need to start doing it. Now, I'm not going to talk in any detail about oxygen equipment, except to say you can get oxygen from a range of different sources, and each of them come with their pros and cons, their different needs. But I do want to just briefly touch on the question of what is medical grade oxygen. So WHO and the regulators define medical grade oxygen as greater than 82% purity. As you know, air has 21%, so 82% is a lot higher concentration than what we're regularly breathing. There's often a lot of confusion about the difference between cylinders and concentrators, and the idea that cylinders are somehow more pure than concentrator-derived oxygen. The reality is that the oxygen in cylinders is derived from exactly the same process as concentrators, so pressure swing absorption, PSA. And typically when we test the cylinders in most hospitals, it has a purity of 90 to 95%, similar to what comes out of a functioning concentrator. To increase the concentration up to 99% is very energy intensive, and at least in lower resource center settings is rarely done and rarely provided. The main difference between cylinders and concentrators is the outlet pressure. And this is really relevant if you're attaching oxygen to a ventilator or to something else that needs that higher outlet pressure. And I would say there are ventilators that can run off the lower pressure from a concentrator. In the end, when we're giving oxygen to patients, the FiO2, or the concentration of oxygen reaching the lungs, we don't want to be that high. So when we're giving it through a nasopharyngeal catheter or nasal prongs, it mixes with air so that the actual delivered FiO2 is much lower, more like around 30%. And that's certainly much safer. We're not wanting to get 90% oxygen pumped into the lungs directly. All right, so what about oxygen safety from a clinical perspective? So there's three ways we can cause harm with oxygen. One is not giving it or not giving enough. Second is giving too much, and this causes oxidative stress on the body. The big examples are retinopathy of prematurity in preterm and neonates. We know that in the 90s, we saw ROP epidemics throughout Eastern Europe and Latin America. In the 2000s, we saw ROP epidemics in East and South Asia. And now this decade, we're starting to see an ROP epidemic in Africa. So all my African brothers and sisters out there, now's the time to prevent an ROP epidemic in your settings. And really the key to that is restricted oxygen use. So you'll see that's why the guidelines around oxygen for preterm and small neonates specifies a target of around 88 to 94% or something similar. And I've put up a couple of the WHO guidelines for reference here. The third thing we can do wrong with oxygen is to give it variably. So Scott Haldane over 100 years ago described this as like bringing a drowning man up to breathe and then pushing him under again. But that's still what we're doing if we're using oxygen from an unreliable supply where it's running out, going on, going off, going on, going off. So in practice, how do we address this? Well, again, the key is pulse oximetry. Secondly is having clear clinical guidelines that nurses can derive their guidance from, and empowering the nurses to do the oxygen titration. I've put a link here to some quick reference charts that you can edit if you don't have your own local guideline, which are based again off the WHO recommendations. Thirdly, we need to have age-appropriate delivery equipment. I'm not going to talk about this in detail. Nasal prongs or catheters, usually what we recommend for children. Humidifiers are really only required if you're using higher flow rates. So if you're concerned that they're an extra source for contamination, then you can leave them off when you're providing standard low flow oxygen to children and neonates. And finally, a quick note just on air oxygen mixers. If we're using high flow or CPAP, then we really ought to be using either air or air oxygen mixer. If we're using oxygen straight from a cylinder or concentrator to drive the high flow or CPAP, then we're really putting these babies at significant risk. Now, a couple of brief notes just on technicians. Really, really important to include them in all our discussions around oxygen. Too often they're not consulted when equipment's bought. They're not told when new equipment arrives. They're only called when things break down. But technicians can really do magical things with oxygen if they're given the chance. And here you can see a picture of a system that we set up from an oxygen concentrator piped with simple plastic piping to 5 beds. The nurse can individually titrate the oxygen to each of those beds and keeping the oxygen equipment well away from the contaminated areas of the patients. Now, this is a general pediatric ward. Similar things have been adapted and promoted for COVID isolation wards. Again, I've put a link up here for some resources to help your technicians. Now, finally, we've spent a lot of time over recent decades trying to understand how oxygen systems go together. I just want to give you 2 messages from this. First, at the hospital level, the key to success is having multidisciplinary teams. So that's teams that involve doctors, nurses, and technicians working together for the same goal. And second, we should be investing in a system, not just in individual bits of equipment. I've spoken a bit about the concentrator-based system that we used a lot in Nigeria. It's being promoted by UNICEF for rapid oxygen scale-up in COVID, but I'm not a devotee of any particular system. I just say, find a solution that works for you. You know your setting, you know your strengths and weaknesses of your existing system. I can't tell you exactly what will work best or most cost effectively, but I can tell you that good results come from thinking of the whole system, from planning, financing, thinking about whole of life cycle costing, procuring equipment that's quality, has good technical support, thinking about how to install it in the best sort of way, thinking about how to train healthcare workers, how to support and train technicians. So this was a rapid race through some of the practicalities of getting oxygen to every child who needs it, and hopefully you can all take at least one of these ideas back to your hospitals and colleagues. I want to just leave you with one additional thought from my mentor, Trevor Duke. He recently wrote that in the time of COVID, we need to be, in the time of COVID, disruption to health services will kill more children in low resource settings than COVID-19. And the best way to protect children is to do the basics and do it really well. And for hospitals, that includes oxygen, infection control, protecting staff who are really your biggest asset. Now's not the time for scaling up things like CPAP or high flow if you're not already doing them. It certainly is the time for strengthening the basics of things like oxygen. Now, we've got a bunch of oxygen-related resources that are curated in this Dropbox folder, so you can click on these here, including some direct links to ones that you can directly edit and adapt. And on that note, I'll leave you and hand over to Dr. Aman Pulganbang from the Indonesian Pediatric Society. Thank you.
Okay. Thank you, James. Thank you also for IPA to give the opportunity for me to share this the experience from the Indonesian experience. Okay. I will try to share my slide. Okay, hold on. Okay. Okay. Since the topic now about do no harm, I try to share our Indonesian experience protecting and fulfilling the needs of children in the COVID-19 during the pandemic of COVID-19. So the outline, I will show 2 case illustrations. So how is the COVID-19 in Indonesia and also in Indonesian children, and profile of Indonesian children and school closure. So what should we do? about reopening, and also our recommendation and about our telehealth also consultation. What's the best application that for telemedicine? So this is the first case. Baby MY, 8 months old. This is typical case. We always have it every week, presented to emergency department. Sunday night, about 11:30 p.m. So the baby already sick about almost 1 month. Lack of the insurance, they didn't go to the hospital, the community hospital. So finally they refer from the primary health care with the really bad condition. The lab result, you can see anemia with increased leukocyte and also hypoglycemia, chest X-ray, refill bilateral pneumonia. The next day, 4:55 p.m. So less. So 4:55 p.m. Hello, can you hear my voice? Hello.
Yes.
How's my, okay.
Yes, we
How's
can
my
hear
voice?
you.
Okay. So less than 24 hours, this is the typical case, the baby passed away. The second case is close to Jakarta. So it's not really from Jakarta, and it's a conjoined twin. So it's quite difficult cases. So since 10 days before presentation, they were referred to tertiary hospital, but they say, because due to COVID, they send them home. So the COVID-19 status suspected, but no PCR yet. 10 days post-discharge, baby 1 worsening with the SOB, cyanosis. Baby 2, there is a cough, but there is no SOB. So brought to the regional hospital. They sent to the tertiary hospital in Jakarta. During that time, there is a rapid test. Given oxygen, antibiotic, no improvement, they refer. So this is the picture, how they refer, because there are 2 different provinces. There is the travel restriction, partial lockdown during that time. So there is 2 ambulances, they do transfer in the side of the toll road during that time. But right now, the baby good. Baby 1, this is quite interesting. Baby 1 confirmed COVID-19 positive. Baby 2, negative, about 3 times negative. So this is 2 different cases. The first one, delayed diagnosis, and finally, the prognosis, is not good. The second one, the prognosis is good, even the really, really difficult cases. So how is the COVID-19 in Indonesia? Having said that, the first cases officially declared is 2nd of March. So quite long ago, about 2 or 3 months after Wuhan, and also after United States, after Italy. But after that, the 10 March, there is the first community cases declared. But the problem right now, the test cases is, the PCR cases is still really low compared to South Korea, compared to Malaysia, compared to Philippines, compared to India, even compared to Pakistan. So it's still 2.2 tests in 1,000 population. And the confirmed cases, almost 80,000 right now. But the mortality, we are quite high compared to other countries, so about almost 5%. And the cases, statistically, the children cases are not compared to the adult cases, but it's still a lot, we think, the pediatric cases in Indonesia. The government dashboard does not include data on pediatric positive cases and death. Discrepancy between confirmed cases and probable cases in many areas. Have low number of confirmed cases. Screening testing should be expanded as well as criteria to increase case detection. Problem in zonation, PPE compliant activities, management of indoor spaces and ventilation. Quality control needed periodically to ensure measures are on track. So we are start new normal now in June. So there is a new cluster right now. Even the army school, there is a new cluster. There is a religious boarding school start a new cluster after that. The government we didn't have any lockdown, but there is a travel restriction. So there is no strict lockdown during the first 2 or 3 months. In June, new normal policies start to roll out because they concerned about the economic problem. So which include, there is probably reopening the economic with imposed health protocol despite a rising number of cases. So we have an inequality in COVID-19 management. We have 34 provinces, 17,000 islands with almost 70 million population. So you can see about inequality in rate of testing. Only 10 provinces, less than 5% positivity rate. The rest, 4 provinces, even above 10%. How about in children? A lot of reporting from ABC, Arab News, and also from BBC. We went from the society to House representative to confirm them. We cannot open school yet. And they said it's okay. But the government still said we can open school in the green area. So you can see, start from the 17th of March, we start collecting every week, every single cases from our member who is taking care of COVID. So you can see here the probable cases, the disease cases, and confirmed cases. So there is an increasing number about suspect cases every single week. The mortality from suspected cases about 3.8% in children. And the mortality of confirmed cases, 1.8%. But compared to other children in the area of even in Asia, maybe in the world, we are maybe the highest. And the highest number of mortality below 1 year and below 5. So these children, this baby, they never had their first and their fifth birthday because they passed away due to COVID. What is the comorbidity or infection of our children? CNS infection, tuberculosis, malignancy, malnourished, because we still have a lot of malnutrition and stunting in our country, GI problem, diarrhea, we still have a lot of diarrhea, dengue, we have a lot of dengue also, prematurity, and also there is one cases of the congenital heart disease. So what is our role as the society? Start from 17th of March, the first regular meeting, we have it every single week. The first 2 months, 2 times a week. So all the chapter president, we collecting, we reporting, and also we see what's the problem. And we release recommendation, education for parents, and also triage. And also we distribute PPE to 28 provinces. We didn't give it to the province in Java, but the whole other province outside of Java, we give PPE. And also we start advocating Minister of Health, also Minister of Education, Indonesian Protecting Community, Indonesian Muslim Council, and also joint collaboration with other society. And this is what we have been doing. We give webinar, also we have to go on TV and also collaborating with other society. So the basic demographic in Indonesia, we have 90 million children. And how about the breastfeeding? The breastfeeding, we have recommendation from our society. You can see this here, probably not much different compared to the WHO recommendation. And also with the mother asymptomatic, mild symptom, we can give it if possible. Mother should keep 2 meter distance with the baby. And also with the newborn, the mothers who are suspected can directly breastfeed if antigen test result is negative. Most of them is not different compared to WHO and CDC. So how about back to school? The government said they can go to the green zone, but this is the problem because the result sometimes in the green zone is the result from 1 week or 2 weeks previously. So what is the consideration for reopening school? We have to be really careful. There are almost 60 million of Indonesian children are going to school. So this is what we are worried now. Special consideration, there are 90 million children are going to the special boarding school, especially religious boarding school. There are 19 million, 19 million children. So we have to stop them yet. But some of them, they still do it in some province. There are two important questions. We still, if we want to start opening, okay. The first one is epidemiology. Is it the pandemic under control yet? If yes, okay, the health system, but no, the health system not able to cope. The public health surveillance also is still, the surveillance system not able to detect. So these three things, we don't think these three important questions from the epidemiology, health system, the public health is still yes, it's still no in understanding from our society. So we give a lot of recommendation right now. Do no harm. You can see it, the new normal must be planned with the children, basic for growth and development, and also means to full basic growth and development must be according to the schedule. Immunization services must be fulfilled. And our coverage right now decreasing. Next year, we are afraid about a lot of, another outbreak, diphtheria. Last week, we have 3 diphtheria cases already. So we are afraid another outbreak of polio, pertussis, maybe measles. If the immunization is decreasing. So monitoring of growth development must be done. Every early years education should be performed at home. And the distance learning should be continued and prioritize physical distancing to prevent COVID transmission. And also, we tell our members are ready to work all party and all government coordination during the COVID-19. So recommendation for learning activity, school at home with the online school to be online through distance learning, and school should not reopen until at least December 2022. This is what we give recommendation to the government, to the House of Representatives, and to public, to parents. And we have to perform 30 times number of confirmed cases testing. So we need to give tests. Right now, there are almost 80,000 cases. So we have to perform about 2.5 million testing right now. So we give recommendation also during the COVID, IPS recommend the children stay home. Must take off, clean all pieces, clothing, use equipment, and take shower bath. Not bring children to the public places and crowd. Must always be under supervision, 2 meter physical distance. And children 2 to 18 years adult advised to wear face mask if they go to the hospital and use appropriate barriers, avoid 6 people, wash hands as often as possible, avoid touching. And also IPS support decision to not reopen boarding school yet. And also all students coming in from all cities to self-isolated for 14 days if they still want to open the school or dormitory, but they have to do it RT-PCR examination on students. And also provision of PPE, mask, disinfectant, hand washing, hand sanitizer, thermometer, isolation has to be prepared. Protocol. IPS recommend for school to be temporarily closed. And also we encourage Ministry of Health to provide recommendation to President to close any boarding school that have the house any sick or diseased student due to COVID-19. And this is our online, our telemedicine application from our society. We call that Primaku. This is the first application from our society, all content recommendation from our society, from IPS. It contains immunization, growth tracker, health tracker, and also developmental tracker. So after this pandemic is increasing, right now, almost 300,000 children already listing in this application. You can see most of them, mostly the baby just born. Most of them, they register to our application. And total number right now, about almost 300,000 children. You can see most of them, they put it on the growth data, immunization data, and also growth development data. And we have also telemedicine, what we call Dr. Primaku. So we start practicing with the telemedicine in order, having said that, to do more harm to patient and also to doctor. So I would like to conclude my talk. Do no harm in Indonesia. Children back to school, going to public places or crowd, not yet. Okay, thank you for giving me this opportunity for sharing what we are facing right now in Indonesia. Thank you. I give it back to Bill or Google. Thank you.
All right. Thank you very much for everybody. Lots and lots of information. We have some time for questions, about 15 minutes. And in order that they were received, I wonder if the panelists could make any comments about breastfeeding, non-breastfeeding, the evolution of the guidelines that we have seen around mother-baby contact.
I'll start off, and maybe Vicki wants to.
Okay, that'll be good.
Also, I think we have gained confidence that breast milk is not a route of transmission of COVID-19. And we really can, with much more confidence, encourage direct breastfeeding, because it really is a life-saving intervention and a long-lasting benefit to both babies and mothers. What we need to do is educate parents about really good hygiene, about how to use a mask. That's not a natural skill. And then I think we need to answer their questions and really engage in a dialogue with them to allay their concerns for potential infection. I don't know, Vicki, if you want to add more to that.
Not really. I think that you've mentioned the really key things. We know that the benefits of breastfeeding are so important to, you know, the infant development, to that bonding with the mother, that it's really important. And as I said, at WHO, our clinical team has reviewed the literature and really feels that it's far more important to continue to promote breastfeeding and contact with the infant, and that there are things we can put in place, and we do need to support the mothers and their partners in putting these measures in place, encouraging them on hand hygiene, how to use a mask safely, when to put it on, and if we can support them in that way, that breastfeeding can be done safely and of benefit for both.
Thank you, Vicki. I think there's wide agreement with that. Thanks for that. Let me ask you a couple more questions. Are we seeing more lactation failures with the uncertainty concerning COVID? Does that propel lactation failures? And maybe a companion question, are we seeing more postpartum depression?
So I think this is very situation dependent. Certainly, we've heard of situations where babies are being separated from their mothers for long periods, and we know how crucial the first 2 weeks after delivery is in establishing a milk supply. So that is definitely a hazard when infants are separated. I think we've also got some success stories. So certainly in my region, we are doing much more telehealth, and it's not fancy telehealth with video, it's telephone conversations with breastfeeding mothers. And you can learn a lot about what's going on simply by having a conversation and by providing anticipatory guidance. So I think we've got both challenges and opportunities. Relative to the question about depression, I think there are surveys among mothers and pregnant women that are showing very high levels of anxiety. So really that, I would say, more than depression, has been the strongest signal. And we probably do need to address those issues head on in our follow-up. But we know that there is always that background risk of postpartum depression that's been going on. And we need to look for those individual family circumstances that are going to put a woman at specific risk.
I think maybe all four panelists have some experience in this next question, which is along the same theme, and that's some comments about neonatal ward visiting. I know that's been a challenge in my units. So Aman, you want to have a comments from your country and society?
Yeah, this is the most difficult thing. Well, we encourage, of course, breastfeeding in Indonesia. And what I was presenting is we, well, modified some from WHO and also from CDC, but also with the local needs here. But having said that, in order to answer your question, the problem is really difficult for us to screen which one, the healthy one, the one not healthy. So when people having a baby in Indonesia, everybody will come, you know, and they like to kiss the baby. This is the problem. Yeah. And most of the baby, they don't born, they are not born in the big hospital. They are born in the local with the midwife and also the primary health care.
Yeah.
So even a lot of people, you know, like working in Jakarta, when they have their family delivery in other city, they have to go back to their place to see their grandchildren or to see their children, something like that. So it's quite difficult here to prevent people stop seeing the new baby. That's why we have a lot of baby with COVID-19 positive. Yeah.
Another question was posed, which is, I think, quite difficult, and that is the planning around children returning to school and whether they should be screened and how they should be screened.
Okay. We are not recommended they go to school yet with this situation until December 2022. Because we still have less tests. If they still want to go to school, let's say in the green area, they have to screen by PCR.
Yeah.
Yeah.
Okay.
If there is a positive one, they have to close the school.
Yeah. All right, that's good. Maybe Vicky, there's a question about reusing PPE and particularly masks.
I saw that. So as I mentioned, we do acknowledge that there is extended use of PPE happening. So as the person in the Q&A mentioned, wearing it for up to 6 hours at a time, in particular a respirator mask or a surgical or medical mask. And we know that that is necessary because of shortages. However, once you remove that mask, our recommendation is that you do not put it back on. And here's a couple of challenges. Once you've removed it, it is considered contaminated. And how do you store it in a safe way? I don't think I can give you really good guidelines on storing a mask that's been in a healthcare environment where patients have likely been coughing on you or in your area within 2 meters. So, and as I mentioned, there was a study that found, coronavirus, the SARS-CoV-2 virus on a medical mask 7 days after that mask was removed. So I think we need to be aware of that. And then how do you take that now contaminated piece of equipment and put it back on your face in a safe way and not contaminate yourself? So those are the reasons why, from an infection control perspective, we would say, no, please don't reuse your mask. Once you've removed it, it's to be discarded or sent for, if you're doing some sort of decontamination with ultraviolet light for UV, that you do that.
Thank you. Hamish, I was wondering if you had some advice on oxygen management challenges, or maybe the worst things or the best things around children with COVID. There's obviously Aman's case studies showed oxygen requirements in some of these babies. And you'd like to make a few comments?
Yeah, sure. I've got to say, I have very little direct clinical experience with this because in Australia, we've been relatively fortunate in not having too many cases overall and too many pediatric cases. From my read of the guidelines and the evidence, the recommendations around oxygen use for children for COVID is essentially the same as for pneumonia, and particularly viral pneumonia. So in terms of starting with standard flow rates, giving it based on pulse oximetry, and only escalating care in the case of treatment failure. So I think my overall message would be to do it in accordance as you would with other viral pneumonias, with an expectation that there'll probably be a longer period of oxygen dependence.
Yeah, thank you. Susan, there was a question about the chosen route of delivery in COVID positive cases. And I think you made reference to that, but do you want to pick that point up again?
Yeah, Bill, just to re-emphasize that there really is no proven benefit to C-section delivery. And delivery should be by vaginal route unless there are very specific obstetric indications. So in the case series that have cultured babies early, it appears that babies who are being delivered by C-section have RT-PCR detection of virus also. And C-section delivery really isn't protective. That's likely contamination, not true infection. But I think we need to re-emphasize again the basics. C-section exposes women to greater hazards, and it really has no proven benefit for either mother or baby unless the mother is in distress. Or the fetus is in distress.
Yeah, thank you very much. There was a question about prematurity rate. Obviously, in some of the case series, the rate of prematurity seems like it's been, premature delivery has been kind of high. Do you want to address that again?
And I think it's important to emphasize that it doesn't seem that COVID-19 really is responsible for triggering spontaneous preterm labor. But in settings where women are being actively monitored, where they may present late for care because of fear of going to the hospital or not recognizing what's going on, that's when women get in the situation of having either very severe illness or of having fetal distress. And it's really this sort of iatrogenic prematurity delivery because of this distress. So I think the challenge for us is going to be to get women to attend to their symptoms, to get supportive care early, much as we've learned for adults. That can really avoid hypoxemia and stabilize women with a lower level of support. And many women have been able to be supported through to continue their pregnancies. And that's the ideal that we want to see.
Thank you. Thank you. John, we're out of time. And so Dr. Klein, would you like to say a few last words?
Let me turn that over to Gagan to close. Thank you, Dr. Keenan.
Right. Thank you, John, and thank you, Bill. As we conclude, the message is loud and clear. We all need to lend our collective voices and use the right global evidence to guide local actions, be it regarding breastfeeding or rooming in of the baby and the mother, reorganization of services in the hospitals, or even school reopening. This will be critical as we struggle to protect and preserve the lives of millions of mothers, newborn, and children, which truly hang in balance today. With this, on behalf of IPA and UNICEF, once again, thanks to all the panelists, IPA office in India, Naveen, Errol Alden, John, and Bill, and to Susan for all her coordination, and to USAID team for supporting this from the background. We will be back soon. Goodbye till then.
Thank you.